Hello, I'm Suzanne Oparil. I'm professor of medicine and director of the vascular biology and hypertension program at the University of Alabama at Birmingham in the US. I also am a past president of the American Heart Association and was involved in the leadership and the steering committee of the ALLHAT clinical trial. There was a great need for ALLHAT in the 1990s because it had not been clearly shown that any particular antihypertensive drug would prevent heart attack, stroke, heart failure. And there were a number of new classes of antihypertensive drugs, such as calcium channel blockers, ACE inhibitors, angiotensin receptor blockers, and alpha blockers, as well as beta blockers, that wanted to compete with the standard treatment, diuretics, but the newer drugs were much more expensive, much more costly. And the question was, do these newer agents offer advantage over diuretic treatment in the prevention of cardiovascular disease outcomes? And for that reason, ALLHAT was designed. The primary purpose of ALLHAT was to test whether any of these classes of antihypertensive agents or any of them was superior to the other classes in preventing fatal coronary heart disease and myocardial infarction, as well as a number of secondary outcomes like stroke and heart failure, which now has become much more important in the world as a cardiovascular outcome. Since beta blockers which were one of the major classes of antihypertensive medications, had been shown in previous trials to prevent cardiovascular disease events, they were not included in the randomization as choices of therapy. ALLHAT was the very largest randomized controlled trials of cardiovascular disease outcomes, ended up with more than 33,000 participants located in the United States and the Caribbean islands. It was very well designed, very well balanced, comparing to the diuretic chlorthalidone, the calcium channel blocker amlodipine, the ACE inhibitor lisinopril, and also an alpha blocker. But the alpha blocker was dropped out early because it did not lower blood pressure as well as the other agents. And it also led to an increase in heart failure. The large number of patients and a large number of centers were very well followed. The results were very well documented and the outcomes were very clear. The inclusion criteria included individuals over 55 years of age at increased cardiovascular risk related to their blood pressure, also to other coexisting conditions such as diabetes, smoking, low HDL cholesterol, and so on. There were a number of considerations so that we selected high-risk individuals to join the trial. The primary outcome was fatal or non-fatal MI, myocardial infarction. And the secondary outcomes included all-cause mortality, heart failure, stroke, and a variety of other cardiovascular events. So it was very comprehensive accounting of what could happen to a patient who had hypertension. The major finding was that the newer agents, that is the calcium channel blocker amlodipine, the ACE inhibitor lisinopril, were not better than chlorthalidone, the thiazide type diuretic, in preventing the numerous cardiovascular disease events that were considered outcomes, and particularly fatal or non-fatal coronary artery disease. There was no respect in which any of the other agents was more effective than chlorthalidone, and chlorthalidone was more effective than the others in preventing some key events such as heart failure. So the bottom line was the interpretation of the investigators that there's no reason to place any of these newer classes of agents ahead of chlorthalidone in treating patients with hypertension. ALLHAT showed that most of the participants, about 2/3 of the participants, needed more than one drug. And it was showed that chlorthalidone also was very well combined with either an ACE inhibitor or a CCB, or even some of the other agents that were not specifically listed as choices. Patients could be treated with other agents if needed, and as I stated before, most of the patients needed more than one drug to attempt to achieve control, blood pressure control. Yeah, one major challenge was that initially an alpha blocker, doxazosin, was included as one of the treatments, but it was found early on that doxazosin was A, less effective in lowering blood pressure, and B, the treatment led to an increase in heart failure events, so that the doxazosin arm was stopped early on. I was involved, as I stated, I was involved in ALLHAT right from the beginning, so I was aware of the dramatic results showing excellent outcomes with chlorthalidone. So I never used any thiazide type diuretic other than chlorthalidone, and chlorthalidone is recommended by the most recent US national guidelines and most guidelines in the world as the diuretic of choice for treating hypertension. Second of all, I became aware that amlodipine is a superior calcium channel blocker, and I choose it as the calcium channel blocker of choice if I need a vasodilator. The ACE inhibitors such as lisinopril are also very valuable. So I choose those agents because of this dramatic demonstration of reduction in cardiovascular events above others.